I'm Dr. Syed Musa. So today we are going to cover infective keratitis. So coming to infective keratitis, it's an important topic. There are four types: bacterial, fungal, acanthamoebic, and viral. So infective keratitis or corneal ulcer, which is otherwise called corneal ulcer, it's basically there is a breach in the epithelium along with an infiltrate. Unlike in surgery, breach in the epithelium is called an ulcer. Here there should be a breach in the epithelium and there should be an infiltrate, which is a pus. So coming to factors predisposing for development of ulcer, in a normal cornea it doesn't happen. There should be some reason for the corneal ulcer to happen. So these are the factors like trauma, foreign body, contact lens misuse, misuse of anesthetic drops, prolonged steroid use, or any ocular surface disease like herpetic keratitis, bullous keratopathy, dry eye, chronic blepharitis, trichiasis, entropion, severe allergic eye disease, exposure corneal anesthesia. All these things can cause development can be a factors predisposing to the development of corneal ulcer. But there are certain organisms that can penetrate an intact corneal epithelium, like in the case of Neisseria gonorrhoeae, Neisseria meningitidis, Corynebacterium diphtheria, Haemophilus influenza, Listeria. These bacteria can penetrate intact corneal epithelium. So if the organism comes and touches the epithelium, it can penetrate and it can cause corneal ulcers, because there is a breach in the epithelium and there will be an infiltrate because of this, because of these organisms. There is one organism which can penetrate the Descemet's membrane. All these organisms which I said can't penetrate the Descemet's membrane. But what happens is, these organisms, they can erode all the layers of the cornea. Descemet's membrane is the internal layer of the cornea. So these organisms can destroy all the layers of the cornea except the Descemet's membrane, and there will be a descemetocele, that is bulging of the Descemet's because of the internal pressure, and it opens up. That's how these organisms causes endophthalmitis. But generally these organisms cannot invade, they don't directly invade the Descemet's membrane. There is only one organism which can enter and penetrate the intact corneal Descemet's membrane, that is fungal corneal ulcer. So we'll talk about that in a few minutes. So these two types, bacterial and fungal corneal ulcer, we have to differentiate it in order to understand it better. So coming to the bacterial corneal ulcer and fungal corneal ulcer, history, both will have same history. There will be a predisposing factor, but for fungal ulcer there is a specific vegetable matter. So the history will be like farmer went into his field and suddenly he got this disease, blah blah blah, like that. So that is fungal corneal ulcer, vegetable matter. And symptoms, both will have same symptoms: blepharospasm, photophobia, lacrimation, all these things. But fungal corneal ulcer will have more of signs than the symptoms. So other points about the ulcer itself: the bacterial ulcer, it is well defined, clean, usually single, and there will be no associated feature. Whereas fungal corneal ulcer will have indistinct feathery margins and necrotic base, multiple ulcers, which is satellite ulcer, and this is the immune ring surrounded by an immune ring. So as I already told, signs are more prominent than the symptoms. So basically what happens is, the patient will be happy because there won't be much symptoms, and the doctors will be alarmed because there are more signs. All these signs will be there, all these feathery margins, satellite lesions, and immune ring, all these things. And coming to the hypopion, we'll talk about hypopion in detail. Okay, so it will be sterile and mobile in the case of bacterial ulcer, whereas non-sterile and fixed in the case of fungal ulcer. The reason being, as I already told you, the fungal ulcer can penetrate the Descemet's membrane. So because it penetrates the Descemet's membrane, what happens is it will be infective. So if you take a tap of anterior chamber tap and you send it for culture, there will be fungus growing there. That's because the fungus can penetrate the Descemet's membrane, and it contains fungal hyphae. That's why it will be fixed. It will prevent the movement of all these cells. So it will be fixed and it will be like a mesh. So that's why fungal corneal ulcer is non-sterile, which is basically infective, and it will be fixed. That is immobile. Whereas bacterial ulcer, it will be sterile and mobile. The reason being, the bacteria cannot penetrate an intact Descemet's membrane. So what will happen is, these our body will produce cells, immune reactions, that will be seen as a hypopion. So what happens is, if you take the anterior chamber tap of these hypopion and if you send it for culture, there will be no growth because it's all our WBC cells there. And it will be mobile because these are cells, it can move. And as you can see this in this picture, the patient is with his head straight and this is his head with his head tilted. The hypopyon has moved, as you can see. That's why it's mobile, and there is no hyphae to prevent it. Hyphae will be there, fungal corneal ulcer. And coming to the investigation, corneal scraping and staining with gram stain and blood agar inoculation, all these things can be done. And specifically for each ulcer, they'll do specific agars. We can grow that. And coming to fungal corneal ulcer, it's KOH mount and Sabrose dextrose agar, which you would have known in microbiology. Coming to bacterial ulcer and fungal ulcer treatment, it is mostly fortified antibiotics, cefazolin, tobramycin, and fourth generation fluoroquinolones that we give, moxifloxacin, all these things we can give. And whereas in fungal corneal ulcer, it's natamycin, amphotericin B. So here the point is, natamycin is given in filamentous fungi, and amphotericin B is given in non-filamentous fungi. And one important thing here is that atropine should always be given to the patient. So let's say a patient comes and you identify it's bacterial ulcer or fungal ulcer, and you give antibiotic drops or antifungal drops, but the patient will go to another doctor because there will be excruciating pain because of the ciliary spasm. So the patient should be given atropine drop. You should treat the cause and you should relieve the pain from the patient. That's when they'll be happy and they'll come to you again. And other surgical treatment would be debridement, and then therapeutic keratoplasty, all these things. And there are certain salient key points which you should know. Hypopyon corneal ulcer with rapid progression perforation, pseudomonas. Within 48 hours, the eye is gone. So should be very careful when using contact lens. This is more common contact lens users. That's another MCQ that they can ask you. So contact lens users, the most common infection is pseudomonas, and within 2 days, the eye is completely eroded. And ulcer serpents, these pneumococcus will have a particular type called like a snake like ulcer pattern. So that's what is ulcer serpents, that is pneumococcus. So ulcer serpents with hypopyon is seen in pneumococcus, that's it. And coming to most common causative organism causing fungal ulcer in the world, it is fusarium, and most common in India it's aspergillus. So I already told you, drug of choice for fungal corneal ulcers, filamentous is natamycin, whereas non-filamentous is amphotericin B. Steroids are absolutely contraindicated in both bacterial and fungal corneal ulcer. But viral, I'll tell you, there are certain conditions which we can give. And atropine should be given to all cases to relieve ciliary spasm. So what are the complications? As I already told you, bacterial and other ulcers except fungal ulcer, all the other ulcers cannot cross the Descemet's membrane. So because the Descemet's membrane cannot be crossed, what happens is the Descemet's membrane will be thinned out, it will be separately thinned out, and because there is an intraocular pressure inside the eyeball, this pushes the Descemet's membrane forward. So that will cause descemetocele. So you can use tissue adhesives like cyanoacrylate glue, bandage, contact lens in order to prevent perforation. So that's about, this is a clean descemetocele. I just showed you just to know how it looks, but usually in corneal ulcer cases it will be dirty, it won't be like this. And coming to perforation, what happens if there is a perforation? If there is small perforation, there will be a plugging of iris resulting in adherent leucoma, whereas large perforation will have iris prolapse. So the exudation forms a pseudocornea over it, and anterior staphyloма will be formed because of the protrusion of the cornea with the incarcerated iris tissue. So one MCQ that they can ask you is that the most common cause of anterior staphyloma is corneal ulcer. Then coming to corneal opacity, once the ulcer heals, what happens is there will be corneal opacity. So corneal opacity, it can be nebular, macular or leukoma, leukomatous opacity. So nebular is less than 1/3, macular is half, and leukoma is half to full thickness. So logically we would think leukomatous opacity will have a lot of disturbance, but it's actually nebular. That's the key point, that's the crux. The thing being is because it's slightly there is opacity, what happens is it will diffract the light and causes a lot of scattering of light, and there will be a lot of disturbances in the patient. Whereas macular and leukoma, it's like patch that cannot be seen by the patient, whereas this is disturbing because there will be a lot of glare and scattering of light will be there. So coming to all these corneal opacities, these are the complications, that these are the treatment. We will next go ahead with acanthamoebic and viral keratitis soon. Thank you.